So I'm going to say something that might be uncomfortable, and that's that most dry eye treatments right now, whether they're recommended online or even prescribed by eye doctors, are in fact either incomplete or just flat out wrong for most people. And on today's podcast episode, I am joined by Dr. Laura Periman, MD, also known as the Dry Eye Master, where she primarily sees the complex, the chronic, and very difficult or treatment-resistant types of dry eye, the types of dry eye cases that other doctors can't quite figure out. And today we discuss why dry eye is oftentimes way harder to treat than what most people think, where the common pitfalls are in terms of where doctors might be missing things that contribute to dry eye symptoms, as well as where treatments are, including what's overhyped, as well as what type of treatments are kind of on the cutting edge and we may be seeing very soon. If you're somebody who's been dealing with dry eyes for months, years, and just nothing seems to be working, then this conversation is for you. So let's dive into it. Now, I just wanted to add here that in this podcast, we do discuss diagnoses of certain health conditions as well as certain treatments, but everything that we discuss is always in the form of education and never a replacement for seeing a healthcare professional. When it comes to making decisions about your health, always consult a qualified health professional in your area. Before we get into it, do us a favor and show some love for the podcast by not only liking, but subscribing to the podcast here on YouTube, or follow us on any of your favorite podcasting platforms. Dr. Laura Periman, again, thank you so much for being here and spending some time with us. Your knowledge and expertise in this space is kind of unmatched, in my opinion. So again, you're like the mentor to me from a distance, and
Aww.
This is again, an honor as always to have some time to speak with you.
Always a privilege.
So just to jump right in, let's do some true and false questions.
Ooh.
Okay, some of these will probably
Not
be
truth and dare, true and false, huh?
true and false.
Okay.
Yeah.
Got
it. I imagine some of these questions might be a softball question for you, but some might be a little bit tricky.
Cool.
So
let's do it.
Starting off, true or false only.
Okay.
Because there can be a lot of nuance, and we know there is. But most
what do I do if
dry
there's
eye
nuance?
cases,
How do I answer it if there's nuance? What do I do?
that's the hard part. True or false only.
You're forcing me to answer.
Forced
All
answer.
Right. I'll give it my best.
Most dry eye cases are caused by not producing enough tears.
False.
False. Okay. Watery eyes and teary eyes can actually be a sign of dry eye.
True.
Drinking more water will fix dry eye disease.
There's a trick word in there, so I'm going to say false.
Okay. Screen time causes dry eye disease.
False.
Omega-3 supplements are helpful for dry eye.
True.
And how about preservatives in eye drops can actually make dry eyes worse?
Absolutely true.
That one, not just true, absolutely true. That's good. And then the final one, and I think this is a great just kind of segue, but dry eye disease can be fully cured.
False.
So lots of, again, some of those are like, there's a one word in there that gets nuanced, right?
Yeah. You did a great job with those. I mean, those are really good thought provokers, and I think it's a good
So to dive really into the conversation, because there's so much knowledge I know you have in this space, let's just start off with like the frustrations that patients have around dry eye, but why do most dry eye treatments fail?
Why do most dry eye treatments fail? Well, I think if you take a 30,000-foot view of that question, it makes sense. So by very definition, dry eye disease is multifactorial, which means there's a whole lot of things that contribute to it, right? Dry eye is just the downstream outcome of those multifactorial problems. So knowing that, and knowing that it's rare to see with someone with one driver of their dry eye disease. Most people have 5 to 10 drivers. of their dry eye disease. It makes sense that you need to identify them all and then pick the right tool to knock off that mischief maker component, driver to that. And also, if you're just treating the downstream consequence of all those things, that's all you're really doing, is treating the downstream consequence. You got to hunt upstream for the actual source.
Yeah, that's something that I think I've had to kind of retool how I thought about dry eye as I started to better understand it. It wasn't just, we just need to just tackle the one spot of like inflammation. But then, it's like, great, we handled that part of dry eye, but everything else, like where did it really come from? Maybe we're not addressing, lifestyle things that may be triggering it. Like you said, they can have 10 different potential causes. What do you see probably as some of the most common, like, contributing issues of why these either potentially causes for dry eye, or why do you think they fail? Why do you think people struggle to get all the pieces to fit?
Right. So what are the main things? I would put them in two main buckets. The reasons for failure are inadequate relief with common therapies, and that surrounds skin conditions, dermatologic conditions. I'm blown away at the overlap between skin conditions and ocular surface disease. And we'll get into that, I'm sure. The second category is germane to neurosensory compromise, which is also part of the definition. And we've been trained to think of just the corneal nerves and the lacrimal functional unit, but that's only one teeny weeny little part of the neurosensory driver mechanism. To me, neurosensory compromise can be anything from the front of the eye to the back of the head and everything in between. So that helps to explain things like sleep disturbances, anxiety and depression, and that bidirectional overlay for a lot of our dry eye disease patients. So I think those are the two main buckets that I see on a routine basis as a referral center for inadequate response to good treatments. They come in with good treatments on board. It's just not enough because of these other co-conspirators that need to be identified and addressed.
So you find a lot of patients who do, because I know with your clinic, your specialty, your dry eye center of excellence.
Yeah.
Is that
all
the
we
right
do
name
is
for it?
dry eye disease. Yeah.
And you guys do a lot of research as well. And so I imagine, a lot of people are seeking you out for maybe their third or fourth or fifth opinion because they've tried so many different medications, so many maybe in-office procedures too, and something still may be missing.
Yes.
And I know I absolutely love your clinic. So perhaps, hopefully next time I'm out towards Seattle, I'll get a chance to see it all again.
Yes.
I know one of the biggest things that our industry in eye care, and perhaps some of our listeners have already heard about Meibomian gland dysfunction before, but that is a big area where I feel the industry is still very much hyper-focused on. Many eye clinics have at least adopted some level of treatments for Meibomian gland dysfunctions. But I would love to know your thoughts. Like, what are your thoughts and concerns when it comes to that major component of the discussion with dry eye?
Yes. So, again, I think Meibomian gland dysfunction is the downstream consequence of a whole lot of mischief coming from a whole lot of different directions. And the easiest way to think about this is an acronym. I call it the BESTO. Rawr. He's laughing at your warm, wet washcloth, right? There's 6 interrelated mechanisms for MGD, and they're very much on top of each other, and one begets the other. There is no single A to B to C to D aspect of this. So B of the BESTO is bugs, and that includes bacteria, staph, strep, Bacillus aeroneus, and Demodex, right? But it also includes seborrhea. I think you're going to see a nice emergence of strategic therapies to address skin flora dysbiosis in the coming 1 to 2 years that can be more effective for a lot of these patients. So that's the B. E is enzymes. The biochemistry of proper meibum production is staggeringly complex. And it starts with the stem cells, the Meibomian gland stem cells. They need nourishment. They need an environment that doesn't have inflammation in order for the genes in the stem cells to make the right enzymes to do that complex biochemical transformation from cholesterol into the ideal mixture of waxes, sterols, proteins, and lipids. That ideal proportion is what healthy meibum looks like. And when any of the component of those four things gets out of whack because of altered gene transcription or suppressed gene transcription, like statins contribute to MGD, it directly competes with HMG-CoA reductase. That's a lot of words, but it's a specialized enzyme that the Meibomian gland stem cells use to help produce healthy meibum, healthy product. So the enzyme part is another key part of it. I is inflammation. Inflammation surrounding the Meibomian glands. The cytokines diffuse across the basement membrane and make the Meibomian gland stem cell sick. Also alters gene production. And it reminds me of how I explain it to patients is like, if you're in a smoky enough bar, your eyes are going to react, right? So like the Meibomian gland stem cells, they're surrounded by all this nasty smoke and toxic cytokines that are making them not perform well and not feel very good. S is stasis of the besto. Most people don't know what stasis means. The common term for it is constipation. Everybody knows what that is, right?
I have a very different image around what Meibomian glands look like now.
Exactly. And when you've done your expressions and you've gotten a lot of stuff out of there, you know what I'm talking about with stasis and constipation. T is altered melting temperature. That's why we do things like radiofrequency, hot compresses to help melt the waxes, oils, and sterols so that we can get them out of the Meibomian gland orifices. And then lastly is obstruction. And that's where superficial obstruction of the terminal ductules comes into play. That can happen in response to chronic inflammation. So when I say these 6 parts all relate to each other, you're starting to understand why, right? Now, here's the other vexing part of this is I don't have anything in my toolkit that addresses all 6 heads at the same time. We have to layer on therapy. And as a patient, that can be frustrating to hear. It's like, what do you mean there's not just a pill I can take or a procedure I can do? It's like, well, there's 6 of these things contributing to the problem. And I don't have anything, I don't have a silver bullet. I have things that address 5 out of the 6 heads, like IPL. The one thing it does not do is it's not a heat modality. It's not a T. It doesn't alter melting temperature. Things like Lotilana or Xdemvy, awesome for the B. A common underdiagnosed component of the bee is seborrhea, fungal organisms. And I don't know about you, but I'm seeing this pattern play out in our clinics all the time. I'll have a patient come in with rosacea and Demodex, MGD, uncomfortable eyes. And I'll ask them, it's like, hey, and I'll see signs of seborrhea, like the flaking hair, a little bit of oiliness, flaking in the scalp. And that weird saponification on the lid margin after a diagnostic gland expression. I'll say, hey, did you have dandruff or oily hair as a kid? It's like, oh, yeah. And how about acne? Did you have acne as a teen? It's like, yeah, I have more than average. Well, 20 years later, they show up with rosacea and Demodex and seborrhea. So it seems to be some type of natural progression there that I'm still unpacking, but the pattern's playing out consistently.
Thank you for mentioning a lot of this because I've been following along with some research and obviously discussions with other practitioners, and this issue around fungus is kind of this big question mark. Like we feel like something is here. There seems to be patients who just don't respond the same way to other treatments, and there is, it definitely seems like there is a connection there. And like we know that there's certain specialized microbiomes throughout the body, right? Whether it be the eyes, certainly the GI, any place that there's moisture, even your armpit, right, has its own, like, it has its like own microbiome in a way. But the eyes having moisture and having very specialized glands around it, and and then most people avoid cleaning or even kind of removing bacteria or anything around the eyes because they're so sensitive, right? We're very protective, and so. Yeah, this is a good conversation. When you have patients that you have suspicion for that, is there anything that you find works the best or in those cases?
I'm so glad you asked. So, yes. those recalcitrant MGD cases, I'd say about 15% of them have this seborrhea component. I don't know if that tracks in your brain, but it seems to be about 15%. And I find that if I treat it head on in combination with all these other things, I get much better relief for my patients. So treatment for seborrhea, or the fungus among us, the fungal component, is we do a stack. So step number 1 is low sugar diet and a multivitamin, multimineral. You got to have selenium. You got to have vitamin D. You need that stuff. But get the sugars out. Bye-bye. Not your friend.
Darn that chocolate I ate earlier today.
If it's super dark chocolate, you're fine, honey.
Dark chocolate, but I know I ate a little too much, right? It was like one piece of dark chocolate suddenly became 2, suddenly became 3.
We can do an intervention if you need. So sugars are hard to give up.
Yeah,
but it's important. And a great multivitamin. You got to get your selenium checked, get your zinc levels checked. So that's step number 1 is nutrition. Step number 2 is hygiene. Step number 3 is ketoconazole 2% shampoo and face cream. So those are very affordable, thank goodness, prescriptions, like one of the few things that's affordable. Ketoconazole 2% shampoo, you put it on your scalp twice a week and really work it in there. It's a scalp medicated treatment, right? It's not a luxury salon shampoo. It's medicated. Really get it in there. Let it sit for 2 minutes. Take some of that lather, do your brows, take some of that lather, carefully paint your lash bases. Take some of it and really get your beard, right? Get that whole beard area really good. Let it sit for 2 minutes while you do your rest of your shower business, sing yourself a song, whatever, and then rinse it off just twice a week. And then the ketoconazole 2% cream can go on in the morning under your sunscreen or at night under your night cream. And that helps to keep the fungal component at bay. And then the last part of that stack, if those things aren't enough, then I will do something called a jet plasma treatment, where plasma is the fourth state of matter. And it uses plasma energy to kill the bacteria, the fungus, and also Demodex brevis. And it helps to stimulate the Meibomian gland stem cells to be more metabolically active and function better. And this has been a technology available in Europe for at least a decade. And so that's what encouraged me to bring it on, because I was encouraged by the results. And then finally, oral itraconazole. I've played around with different dosing regimens. The challenge with oral itraconazole is it has a lot of very dangerous drug interactions, like serious drug interactions. So you have to really have a complete med history on your patient before you even consider doing oral itraconazole. That's the stack.
Well, I appreciate you sharing that, because this, again, is kind of a conversation I know with some different specialists. Even this last weekend, I was listening to a lecture and they shared some different kind of their own mixtures of topical creams and prescription medications that they've been at least trialing out with some patients. Yeah. But I think even they're just navigating this space. Like, how do we get a better response? But I really appreciate you sharing all of that insight.
Yeah.
Now, we could talk about MGD for quite some time, right? And one of the biggest questions that not only I think practitioners ask, but a lot of our patients ask, because they come in and we take meibography images, we can show them how many glands they have. Perhaps there's some inflammation, some are truncated, or some are completely gone. If these glands are dysfunctional, or if they're completely gone, is there anything we do to really get them functioning better? Right. Or could you get them even to come back?
I'm really glad you're asking this question, because it's a source of fear and anxiety amongst a lot of patients. And there's a lot of good news here. So I want to start it off with that, right? Just because a gland is not visible on meibomography does not mean it is dead. It may not be functioning well. All that tells you is that it's not visible on meibomography. Meibomography is an imaging modality. Full stop. That's all it is. So we often will see improvements in the dead zone or areas where it looks like there's gland dropout. You can nurse them back to some function and some health. I call that the Princess Bride effect. It just looks mostly dead. It's not all the way dead. And we can bring it back to life.
That you get so many points from me because you just referenced Princess Bride in a dry eye related podcast.
It's one of the best movies of all time.
Yeah, it was one of my favorite movies as a kid growing up. So yeah, shout out to, well, rest in peace, Rob Reiner. But still, yeah, thank you. Billy Crystal was amazing. So, but back to that, yeah. So you're saying they're mostly dead, but they're not all dead.
And they're not all the way dead. Like we can revive a lot of function in them. And just because it's not visible in mammography doesn't mean nothing's coming out. Right? So have you had those where you're like, oh my gosh, there's 3 that look like they've dropped out. And then you go to push on, it's like, well, they're producing oil.
Yeah, I have seen a couple of those. I've been surprised, happily surprised when I'm like, oh, I'm still actually getting some secretion.
Right. So structure and function, I think, is the intersection there. But I think it sounds scary to patients when we tell them they've had gland dropout and they, get very concerned. It's like, oh my gosh, save the glands. I don't want to lose them all. And it's like, first of all, we've got time, right? Second of all, I'm not going to let that happen on my watch. And third of all, that just means it's not visible in mammography today. That is not true forever.
What I know in our clinic, we have access to intense pulse light. We have RF that we utilize, or radiofrequency, bipolar radiofrequency specifically. And I've used multiple different treatments over the last 10 years of my practice, but you obviously are involved in a lot of the research and you've established protocols for things like intense pulse light treatments. What are you finding works? You can't say for everybody, but what works for probably the majority of Meibomian gland dysfunction treatment that you find it probably the best results with?
Oh, great question. My workhorse is still IPL. Like I can throw that football further downfield with my IPL than pretty much anything else in my toolkit. But I will say there's oftentimes where that's not enough and I have to pull out other modalities like the jet plasma treatment and things like radiofrequency plus deep muscle stimulation. We have data showing improvements in Meibomian gland secretion scores and dry eye symptoms in patients that have been treated with specifically TriLift and OptiLift. So I tell patients, let me back up and explain why this is helpful. So the RF melts the waxes and sterols that are solidified in the Meibomian glands. And then the muscle stimulation, it's literally electrical impulse. And so the muscle will twitch under the stimulation and it's pumping out a little bit of meibum. So it's very physiologic, but more than that. And I'm so excited to share, this is my independent research. I don't have any support for this research. I'm a nerd and I like knowing how things work. So I'm like, ooh, we got to measure this effect that we're seeing, right? So we have data showing improvement in incomplete blinking, which I think is another reason for recalcitrant MGD and persistent symptoms in patients that have received good care otherwise. So yeah, what I did, I'm so proud of this. We took videos under fluorescein at a set distance and recorded 60 seconds. Then we exported it into a customized Python program to count the green pixels frame by frame over 60 seconds. So it generates the spreadsheet 1,200 lines long for just one eye, for one study. And we did it pre and post the TriLift, OptiLift treatments. And I'm able to quantify for you the improvements in the blink cadence, frequency, amplitude, spacing, standard deviations, and completeness. So cool.
That is really cool. I know the blink rate and incomplete blinking is, how many patients I show them pick like videos like, do you notice this? What are your thoughts? And, like the pointing out the incomplete blink is like, whoa, I didn't know. Like most people have no idea that they're just not closing their eyes all the way. And if this is occurring all day long, just
all day long,
that tear film instability is just exacerbated by that exposure.
Yep. Which is another interesting component to this whole, gnarled ball of yarn we're talking about here. That incomplete blink. One of the other consequences of that, not only are you not wetting and spreading the tear film, you're also not engaging the muscle of rheolon, which is this tiny little circular muscle around each Meibomian gland, and it only fires when you have a complete blink. So if you're incomplete blinking all day long, there's no milking effect of the meibum. Nothing's getting pumped out to protect your tear film. So it turns out the complete blink is critically important.
Which, right as you're saying this, I'm sitting here like trying to fully blink my eyes a few times.
Let me just do the treatment for you. I call it physical therapy for the eyelids.
So that is definitely kind of I think a branching area I've been more interested in. We're looking at bringing those sort of technologies to our practice as well. I do want to kind of shift gears a little bit because you mentioned inflammation, and inflammation plays such a big role in not only kind of one of the main drivers behind dry eye, but plays such a pivotal role of why dry eye is hard to treat, right? It's one of the big kickers for the vicious cycle of dry eye. Can you just talk a little bit more of how you envision and think about inflammation and like how this ends up causing more damage down the road?
Yes. So I'll talk about it at a high level and then specifically of how it fits into MGD. Actually, I'm going to do that in the opposite. So is it a chicken and egg or a horse and a cart, right? Inflammation begets inflammation. We know that. But where did it start? Where did it come from? At one point, your eyes were pristine and you had no symptoms and you had no inflammation. How did this thing get going? And I think that harkens back to the multifactorial nature of dry disease. Even seasonal allergies can create MGD, right? We know that there's a inflammatory bridge, an immunologic bridge between the allergic conjunctivitis response and Meibomian gland dysfunction. And that bridge is through the specialized white blood cell called a poly or a PMN. And there's only 3 things in your toolkit to beat down PMNs. You only have 3 things. You have steroids, you have Xiidra or lifitegrast, and you have IPL. That's it. So all those seasonal allergies that you had are contributing to your Meibomian gland dysfunction. So that's one form of inflammation, is the allergic response. The classic immunology that I think you're referencing is where we target with our immunomodulators, like Restasis, Xiidra, Cequa, Vivai, Verkazia. These are all fabulous immunomodulators that are specifically designed to limit the conversion and the amplification of inflammation. So there's this innate immune response and there's an adaptive immune response. And in a normal, healthy system, you're supposed to have both an innate response. Right now, it's like a trigger happy thing, and then the adaptive immune response. But in a healthy eye, you're supposed to return to homeostasis. That return is what's offline with chronic dry eye disease. That you never do return to that same happy state of checks and balances. It's just a runaway freight train of chronic inflammation, beginning chronic inflammation. And it centers around T cells. So all of our immunomodulators are targeted at T cells, specifically Th1 and Th17 cells, but there's other types like Th2s. And that's where things like allergies come in and things like atopic disease comes in. So it's not a straight line. The immune system is fascinating. It's so redundant, and it like the proportion of certain cytokines compared to others can make a cell turn into one versus the other. And it's,
Right. I challenged myself about a year and a half ago to think like, okay, you hear on social media, you hear so many people just use the term inflammation to just try and kind of explain almost anything in terms of the disease process. But I was kind of wondering, I'm like, we talk about inflammation so much in eye care because inflammation can cause significant damage to the eye, right?
Oh, yeah.
Like a uveitis, for example. But I was wondering, like, what really is inflammation? Let me go back to my fundamentals. And I had to pull out my undergrad textbooks in immunology and basically really reteach myself, like, what are T cells? How do they work? How do they communicate? And even just going deeper than that. And that just changed my perspective.
Amazing.
One thing I think I found kind of fascinating that helped me better understand, at least even sometimes I think recognizing maybe autoimmune related type of dry eye is more problems with goblet cells or severe conjunctival staining that just doesn't seem to resolve. I don't know if you've seen similar findings.
100%. And now you're talking about yet another type of inflammation, right? You're talking about B cell activity, egging on the T cells to create more and more damage. And you're totally right. The goblet cells take the hit. Goblet cells are the unsung superhero of the ocular surface. Not only do they make mucin to wet and spread your tear film, but they also have this critically important immunoregulatory function. That's why the more you have, the more you're able to return to homeostasis. And you're right, in chronic inflammation situations, in severe inflammation situations, the goblet cells are offline. It's, I don't know if you remember from your reading, and I applaud you for doing that, by the way, the IL-1 and TNF specifically, those are goblet cell kryptonite. So
yeah, I'm pretty sure I have at least one lecture slide talking about that.
So the goblet cells can recover. Yeah, it's fascinating how all these things interrelate with each other. And you're right, that staining pattern is a big tip-off to autoimmune disease. When I see that heavy staining nasally and temporally, I'm like, I start asking more questions about review of systems and family history and sending labs looking for biomarkers consistent with autoimmune disease. So that treatment pathway is more intense and it's different.
Do you think there's autoimmune related issues that contribute to MGD as well?
Oh, yeah. Yeah. So riddle me, case in point, have you ever seen a Sjogren's patient who did not have MGD?
No.
Never. Not even once, right? So inflammation begets inflammation, that double vicious circle concept that I'm such a fan of Christophe Baudouin's work. The double vicious circle cycle, like aqueous contributes to meibomian gland dysfunction. Meibomian gland dysfunction contributes to evaporative losses, hyperosmolarity, and then this hamster wheel of misery just gets rolling, right? So you have to intervene with all of your strategies, your in-office treatments, your prescription treatments, all the things.
Now, again, this is slowly turning into like a masterclass on dry eye, which we don't have the time for. But I know earlier you did reference the neurosensory component, right?
Yes.
Because the nerves of the eye play a big role, and we've talked about that in some previous episodes. But can you just kind of help us understand where corneal nerves come in?
Yeah.
And how chronic inflammation kind of fits into that.
I would love to. So it turns out the corneal nerves are like the rheostat in the room you're sitting in. It's constantly sampling the quality of the tears. It's like, how salty is it? Oh, I need a little more tears here. Or that's a lot of wind. That's too high of an evaporative rate. I need more meibum. I need more aqueous. Hey, goblet cells, fire up the grill. Like, all those types of things. That's the lacrimal functional unit. So they're constantly sampling what's happening in the tear film and making these micro adjustments. And you're supposed to happen without your awareness, without discomfort, without visual disturbance. That's not true with a dry eye patient. There's constant awareness and visual disturbance and discomfort. So that front line sensory system is critical for maintaining a healthy tear film despite your environmental challenges in any given day. Things can go wrong with that system, such as contact lens overwear, corneal surgery, like with LASIK, PRK, SMILE, all of those things that temporarily cuts the rheostat off the wall, rips it off the wall. The corneal nerves do regrow and regenerate, but that's why people are dry after surgery, even cataract surgery, even retina surgery, retina injections. All of these things can negatively impact that frontline monitoring system and further compromise your tear film. And then there's conditions like neurotrophic keratitis. Most people, I think, are familiar with diabetes and its complications on the nerves, like in the feet, where people can't feel their feet anymore. It's called a diabetic neuropathy. Well, same thing can happen with your corneal nerves. And that's a real common contributor to neurotrophic keratitis, where the nerves kind of regress and they're not functioning very well at all. Chronic inflammation is a big one, right? In my mind, I envision these poor these poor corneal nerves, they're trying to send this signal, help. It's like, nobody's listening anyway. All right, so they just kind of, they go away.
They sort of recede and they stop firing, right?
They stop firing. Nobody's listening to me. But we can get that back and we can restore a lot of corneal nerve function with controlling inflammation, right? We talked about a lot of ways to control inflammation so far. We can get it back with PRP, platelet-rich plasma. We make that in office under sterile conditions. I'm so impressed with that ability to heal the keratitis and to improve corneal nerve function objectively with a Cachet-Bonnet aesthesiometer. I wish I had the Brill aesthesiometer, but add it to the list of toy purchases that I want. But so I can do even better for my patients. But we can, and then the last thing that we can do is something called Synedgermin, which is Oxervate. It's a tough protocol to go through. I can't predict who's going to have a pain, who's going to have growing pains with that strategy, but the medication works. It works very, very well. And then in ultra extreme cases, we can do corneal neurontinization surgery, and that's done at a tertiary care center. But that's a big surgery.
I honestly don't even know too much about that procedure. That's something I'll have to put on my homework list and dig a little bit more into it. I just know with Synedgermin, it's like a hobby kit, right? You get sent all these vials at home on dry ice, and you gotta put them all together, and then your patient's using it for six times a day.
Yeah, for 8 weeks. It's intense.
For 8 weeks. So it's
intense.
I think, and that can be a challenge for some people, just with
especially if you're dependent in sclerals. How do I manage that? I can't function without my sclerals. So it has its application, and I've been happy with it, but it's challenging. And then, of course, not to mention the difficulties getting the insurance to cover it, which is inappropriate in my humble opinion. But that's a sidebar discussion. Anyway.
That might be an interesting separate podcast episode where we just sort of break down how to
fight back against your insurance company who's practicing medicine without a license. Yeah, I'd be on for that.
Yeah, I know a lot of health practitioners of all kinds would love to jump in that conversation. I know you mentioned PRP, or platelet-rich plasma, and I feel like there's been more conversation around PRP treatments, autologous serum as well. They're not the same thing, but they're kind of cousins to one another. Do you mind speaking to that and just kind of when you utilize those and kind of your success or concerns with either of those treatments?
Right. So autologous serum is essentially platelet-poor plasma that's been diluted down to a specific concentration. The proteins in plasma can create, I'm going to explain this in a second, but protection against oncotic pressure. So as you have hyperosmolarity, those proteins help reduce the stress from hyperosmolarity from dry eye disease. So those can be very helpful. I've had many, many patients, and it's a great first step, and it's easily accessible. Many, many patients come in where I'm like, gosh, there's still a lot of keratitis, a lot of staining on the cornea. They're still very symptomatic, and the nerve function is down. So let's try a course of PRP 4 times a day for 3 months. And I'm so impressed with how much the cornea heals, the keratitis heals, and the nerve function improves. The caveat, because you asked me what the downsides are, is there's obviously the expense part, because it has to be done under sterile conditions, 1 patient at a time. So there's definitely a cost to it. The other down part is you have to use it cautiously in neuropathic pain patients. Mm-hmm. The platelets may have I'm going to create a lot of alarm but hear me out. Don't panic, people. They can promote inflammation, but mostly they're lower inflammation. So caution in the neuropathic pain situation.
That's good.
There is one more thing I wanted to add.
Please.
When you look at the corneal nerves, think of it as the foremost fingers of reaching of the brain. And then in that cornea, you have your immune cells, just kind of circulating around in the cornea itself. And they talk to the nerves. The nerves and the immune cells, they talk to each other through transient receptor potential V1 and A1 signaling. I call them the vanilla ice molecules. It's like Google Translator, so that the immune system and the nervous system can talk to each other. That language can become dysfunctional and abusive. And so that's where another area where controlling inflammation can help that neurotrophic and neuropathic situation.
I love that. The autologous serum, we've had success with some patients with that. We haven't had access to PRP where I'm currently at. It's something I would love to, if we could bring it into our practice. I know some eye clinics and like yours, you guys do PRP right there at your clinic, don't you?
Yeah.
So you need some specialized equipment and you need to have all the certifications to do everything. So I think that's one of the reasons why I think access has even been a little bit of a challenge for some people.
But I've heard there's hope on the horizon on that. I know Ocubio out of Florida is working on getting their PRP service online. So theoretically, once that gets going, any doctor should be able to enter the order into the portal and get PRP into their patients' hands that way.
So that will be exciting. I'll keep my eyes out on for that. I did want to circle back toward the very beginning. We did talk a little bit about the lid microbiome, right? So what are your opinions on eyelid cleaning and just proper eyelid hygiene beyond the people with seborrhea? Because we talked about your protocols with that.
Yes. So we know that the flora of the periocular area has a normal profile and an abnormal profile. And those abnormal profiles are heavily associated with certain underlying medical conditions like Sjogren's disease. That skin flora profile is wildly different than normal, right? Part of that microbiome is, staph, strep, P. acnes, has a new name. I forget what they're calling it now. The Demodex and the seborrhea. We talked about that a little bit. I worry a bit about excessive use of oral doxycycline. I get most of my patients off of it, and I'll explain why I don't love it here in a second. Actually, I'll go ahead and tell you now. I've had multiple patients on long-term oral doxy develop bizarre things like dacryocystitis with a fungal organism called Candida parapsilosis, chronic canaliculitis, dacryocystitis that requires surgery.
Yeah, those aren't fun.
And so I've seen several cases of those, of longstanding doxy use. We know that doxy at high concentrations is antimicrobial, but it's also antimicrobial at lower concentrations. And I worry about the gut because we know that in rosacea in particular, the gut microbiome biodiversity is compromised. And if you're throwing an antibiotic on top of that, you're actually directly contributing to the underlying pathophysiology of the problem. So it's never been my favorite move. Like I try to get my people off of doxy. That doesn't make sense. And when you look at the Cochrane reviews of all the literature, the evidence is soft at best, right?
They even show that just even using topical like azithromycin is pretty much a similar response.
Yeah. And so you're putting the balance of the biodiversity at risk with excessive antibiotic use, with probably hypochlorous acid use. I worry about that. Actually, I don't know. I'm going to couch that and say I haven't seen a paper looking at the biodiversity in response to chronic use of that. So I actually don't know. But these are random thoughts from a restless mind, like things that occur because these patients come in complicated and I got to figure them out. So I worry about abnormalities in the flora. I will tell you that there is an exciting phase 1 area of research using bacteriophages. So for the audience, bacteriophages are, they look like little satellite landing pods or moon landing pods. And these little organisms inject their DNA into bacteria and it kills them. So we can design species-specific bacteriophages to attach to certain bacteria that can be out of whack population-wise in the skin and potentially kill them off without compromising any of the other normal stuff. We can restore the ecosystem. That's coming. It's so exciting.
That will be because it feels so complex, right? It's like hard to know how do you, once you've already laid these tracks and have this buildup or this altered ecosystem, how do you get it back to a homeostasis, right? How do you get it back to balance?
Luke, I am your father. Restore the balance in the force.
And I think there's a lot of discussion. I'm happy that one of the first things you mentioned was diet, because I know there's a lot of discussion about that in all different camps, right? In between nutrition, dietetics, and there's some evidence, at least for people who have autoimmune, like Sjogren's related dry eye. There is several studies that I've seen that link those together. Although maybe not for everybody, but there seems to be some evidence leaning that direction. That altered gut microbiome seems to prime people maybe toward the path of autoimmunity.
Well, we know that Parkinson's disease is associated with overgrowth of a small bowel organism. So we're finding more and more disease associated with microbiome imbalance.
And of course, then, it's great that so many of us at a young kid were given so many different medications.
Like candy, man. Not good.
I know with doxycycline, I haven't prescribed it for dry eye or MGD for quite some time.
Same.
Because of these concerns with the gut flora. The only time I will occasionally use it is for patients with recurrent corneal erosion. But I always
metalloproteinase load. That's smart.
Anytime I have patients put on an oral antibiotic for any reason, I always have a conversation around eating many different types of food, try to eat more fibrous food, eat diversity. I at least have that conversation. I don't personally put patients on probiotics at this time. I want to see more research on that, but it is on my mind, and I think a lot of practitioners I've been talking to have also said kind of similar things, that they're leaning away from using oral doxy as often.
Good. I'm glad to hear that. There was a paper about 10, 15 years ago in the Ocular Surface Journal. Best nerd reading, chef's kiss. Someday I'll have a paper in there. But anyway, dry eye symptoms, symptom scores for this, symptom scores for brain, cognitive functioning, anxiety, depression, and then global gut symptoms, right? So it's the ocular dysbiosis syndrome. No, that's not what they called it. It'll come to me in a minute. I can't believe I'm blanking on this. I talk about it all the time.
The gut-brain-eye axis?
Yeah, something like that. But that's what it's getting at, the eye-brain-gut axis, right? And so what they did is they did standardized questionnaires on dry eye, cognitive function, mood imbalance, and gut function over 30 days. And half the group got a standard probiotic, and the other half got the bacterial lysate. What does that mean? It's the parts of the bacteria, blasted and blown apart. Inside of there are something called SNRPs, or small nuclear peptide repeats. That's only found when you break apart those probiotic organisms. Well, the group that got the lysate, or the SNRPs, had massive improvements in their scores for their brain function, their dry eye symptoms, and their gut symptoms in 30 days. And so I don't have a $50,000 sonicator to break apart the probiotics, but what I do have is a green veggie shake recipe that I share with my patients. Would you like to hear it?
I mean, what will probably work better is if you share it with me, we'll try to include it as like a download, so people who listen in can find it in the show notes.
Yeah, green veggie shake recipe for restoring your gut microbiome. It's awesome.
Thank you for sharing that.
Yeah.
I know one other thing that you and I have talked about before, which I think we'll have to have you back on in a future episode to do a deeper dive on. But I've had even some patients this last week ask me about makeup and cosmetics. Because, right, if we're talking about microbiome on the eye and the eyelid, I mean, anytime people are using cosmetics and other types of even eyelid creams, right? I don't know. There's so many different ingredients in there that can influence not only like our skin, but the glands underneath the skin and the eyelid, the surface. So, some people are tight lining the eyelids, and so that makeup actually gets in the tear film.
Mm-hmm.
Right. The patient I just had the other day, I flipped her eyelid because she had a foreign body sensation, and when I flipped the eyelid, you can just see all of this deposited. It looked more like foundation.
Wow.
That had been in the tear film so long, for so many years, it had been engulfed and absorbed into the conj.
Yep.
But yeah, what are your thoughts and kind of comments on cosmetic use?
I have lots of thoughts around that. But I'll start by your patient in that example. I've seen the same thing where it's like the particulate matter from either foundation or powder or eyeshadow, who knows, gets into the tear film and it lodges into the conjunctiva permanently. I can't remove it. And you can see it because it kind of twinkles back at you just a little bit. And it looks kind of flesh colored, right? So it's probably foundation. But remember that, this is going to be, okay, I'll try to make this simple. When you're talking about pigmented products, some of them come from earth sources, like minerals. Like everybody thinks, minerals are better for your skin. It's like, are they? Because if you look at them under ultra high magnification, they have sharp little edges, right? So minerals that are used to tint makeup might be part of the cause of that. Certainly loose powders, that gets into the tear film and that can lodge into the conjunctiva. Fibers in mascara, like nylon fibers and rayon fibers, they're added to formulations to help give the appearance of lengthening and thickening of the lashes. But we have multiple cases of the nylon fibers and rayon fibers actually lodging into the conjunctiva of patients. And sometimes it requires surgical removal. So I tell patients to avoid that for sure. I don't want, the mascara is like, the temptation is like to do clean or low preservatives, but that's a double-edged sword. You need preservatives so you don't get a blinding corneal infection or a fungal infection. You need preservatives in your cosmetics. Demodex live up to 5 days in mascara, right? So get a fresh tube if you're being treated for Demodex. You want a formula. Clean doesn't confer safety or tolerability for mascara or any cosmetic. You want something that once you put it on, it stays put, whether you need to put in an artificial tear or not. It doesn't smear, doesn't get into the tear film, and also just comes off easily and doesn't have any of those sharp rayon, nylon fibers in them that can create that lodging in the conjunctiva and further irritation. So it's messy.
Yeah.
And then there's skincare. We didn't even talk about skincare. And the retinol discussion is very controversial. Great for skin, probably deleterious to the Meibomian glands, but yeah.
So then it comes like, how close can you put that retinol cream? Do you use it for the skin and just avoid the eyelids? I personally haven't seen a publication showing like concrete evidence that they're going to cause damage, but I know so many people are.
But not like, the Meibomian glands are buried deep under several layers of skin. So theoretically, it's not getting in there. However, I had my eyes opened by a study I read, it's probably 12, 15 years ago. This was teenagers with acne being treated with a combination Retin-A type treatment to control their acne. And within 4 weeks, half of those patients had dry eye symptoms and they had corneal staining. So they're not putting it here. You don't have pimples here. You have it everywhere else. So the product might have been migrating, right? So that is a concern. Full strength Retin-A probably just shouldn't be used anywhere close on the face, right? Or like maybe here and down and here and up, maybe, but we don't have direct evidence that it's safe. And that Retin-A in particular is the most potent one. And we know that has negative impacts, at least in cell culture.
I know some people who are big in the dermatology world, they'd hear that and they're like, darn it, because it
keep using it
makes the skin
anyway.
look great.
And then wonder why their FTD is not getting better.
Well, we definitely need to unpack that more. We'll definitely probably save that for a future episode just due to time. But because I know so many people are like, okay, I'm hearing all this. Well, how do I look at the package? How do I make sense of it? So we'll save that for another episode.
Okay.
But just thinking about, the whole totality of dry eye treatments of where we're at here today, right? 5 years ago, we maybe didn't have a few medications, even some procedures available. But where do you think the next wave of dry eye treatments are going to look like? Right now, we're kind of on the 4th generation of dry eye treatments. What's the 5th generation going to look like?
Oh, man. So we're going to have tailored specific tools. I'll be able to instead of a sledgehammer, I'm going to have like a chunk, this gorgeous toolkit to address every single specific problem. I'm so excited. There's lots of amazing things coming down the pipeline. There's a topical small molecule nerve growth factor that might be easier to use than Synedgerman coming. I think that's in phase 3 even. We've got selenium disulfide to help with the keratinization of meibum. I told you meibum is lipids, waxes, sterols, proteins, lipids, right? The proteins impart our keratin, and that's broken down by the selenium disulfide. We're excited about have that come on board. Let's see, other big innovations. Oh, recurrent corneal erosion. You mentioned it earlier. That is a weakness. The easiest way to understand recurrent corneal erosion is your epithelial cells have these little roots or anchoring fibrils that attach to the underlying basement membrane, like plants in the garden. It needs good topsoil. So in some patients, the topsoil has been stripped away and there's nothing there for it to hang on to. In other patients, those roots or those anchoring fibrils are damaged, and there's a molecule in development that the anchoring fibrils are like a twisted rope, like a sailor's rope. And imagine it being frayed and weak. Well, this section comes in, bridges that frayed part until it can heal. And now you've got firm roots again. It's so cool, right? So there's all these amazing strategies coming about, and we're learning more and more all the time. It's a really exciting field.
That's exciting to hear that, because I was just talking with a patient this last week that we're treating him for his RCE, and I kind of used a similar description. I use the analogy of Velcro, right? Because the Velcro is kind of like hooked at the bottom if you look under a microscope, and that's kind of how it comes together. But exactly, it takes about 6 to 8 weeks for those to really seal on their own naturally.
Yeah. Yep.
So
it takes time to mature.
Any other thoughts on kind of treatments you're looking forward to? Any new procedures? I know you're doing a lot with plasma pens.
I'm sitting on some data that I can't share just yet. It's killing me. But I can't share it yet.
But I love the fact that you're always on that cutting edge, right? You're always either involved in the research or you're
because there's still unmet need, right? I can't fix every single person with dry eye. I want to. And so it drives me to find more solutions. So we'll be presenting data hopefully in the next season of meetings, scientific paper sessions, looking at ways to mitigate that neurosensory compromise with a drug-free option.
Which I think a lot of people would love hearing that, because it's frustrating when people are like, I'm on 1-2 medications just for dry eye, let alone all the rest to try and manage, whether it be high blood pressure or their cholesterol, anxiety, depression, all of these sort of things. It adds up. It gets expensive, and if there's a one lifestyle thing that'll be good for even one medical condition, it often echoes and has benefits for everything, right? Like sleep. If you could just get consistent quality sleep.
Disturbance is bidirectional with dry eye. Absolutely. I screen a lot of patients for sleep apnea. I catch a lot of sleep apnea.
Right. Floppy eyelid syndrome's a dead giveaway most of the time. Well, Laura Periman, thank you again so much. I was called the LP, right?
LP, everybody calls me LP. You can call me LP.
Well, thank you again so much for your time. I know we've got so many other topics to touch on in the future, so really appreciate you just taking some time out of your day. I hope that everything goes well for the next week, and all of your patients return and they're like just having like the best day.
I love that.
Dry eye symptoms.
I love it when that happens. And I hope so too. And thank you so much for having me on. I really appreciate it. It's always a joy to talk to you. And thank you for what you do with the Eye Health, Dr. Eye Health channel. Like, you make a big difference for a lot of people. And I know it's a lot of work and I know it's a labor of love for you, but I really respect it. And I really thank you for it.
Oh, well, thank you for saying that. We're trying.
Yeah, you do a great job.
Well, thank you so much. We'll talk to you soon.
Take care.
You've been listening to the Dr. Eye Health Podcast with Dr. Joseph Allen. For more resources, trusted information, and helpful tools, visit dreyehealth.com. Thanks for joining the community that's focused on healthier eyes and a healthier life. Until next time, stay informed and keep your vision sharp.